Unfortunately, Jacob's having some tech difficulties, so that's why he's on the phone, but he's on the phone with us, so don't be offended. Hi, everyone. My name is Leslie Hendrickson, and welcome to the Newburyport Literary Festival. I'm on the steering committee of the festival, and even though I can't see you, I am so glad you're here. We're excited about the festival this year. This is our second year online and our 16th edition. We hope to be back in person next year, of course, but this format has allowed us to bring a lot of new and different authors to the festival. And in fact, it's our biggest ever with over 100 participants. Just a couple things before we get started. We're using the webinar format, so you probably know this already, but you'll see and hear the panelists. You won't be able to see yourself. If you have comments, please put them in the chat. We'd love to hear from people. Tell us where you're from, if you're new to the festival, or if you're an old friend. But if you have questions, please use the Q&A tab below, and that allows the presenters to see the questions and keep them organized. As you may have already heard, today is Independent Bookstore Day, and we want to support our independent bookstore partners. Links to our partners, the Bookshop of Beverly Farms and Jabberwocky Bookshop in Newburyport, will be in the chat, and they have all the books from all the authors at the festival. So of course we encourage you to support them or your local independent bookshop. I'm going to give quick introductions to our speakers, but I'm also going to put the link to the Newburyport Literary Festival in the chat, and you can read more about them there. So to start off with, Jacob Appel is currently Associate Professor of Psychiatry and Medical Education at Mount Sinai's Icahn School of Medicine, where he is Director of Ethics Education in Psychiatry. He is also the author of 4 literary novels, 10 short story collections, an essay collection, a cozy mystery, a thriller, a volume of poems, and a compendium of medical dilemmas. Lydia Dugdale is a professor of medicine at Columbia University College of Physicians and Surgeons and the director of the Center for Clinical Medical Ethics. She also serves as the Associate Director of Clinical Ethics at New York Presbyterian Hospital, Columbia University. And she's a practicing internist, plus, of course, the author of The Lost Art of Dying. And so just to start us off, when I read these bios, I think, wow, they're overachievers. They have already achieved so much in the world of medicine. Why write books? And so, Lydia, why don't we start with you?
Well, I'm not nearly as much of an overachiever as Jacob, so I definitely take last place here. For me, I have to say the Lost Art of Dying was a book that I had working through in my head for probably a dozen years. Actually, it's a book I had wanted to write for a long time, but I have had a really, really busy clinical practice. And so writing was not something that I quite got enough time for. Mostly I did short journal articles, but eventually it sort of just came out of me. I just had to write it. And now that I mean, I'm sure literary folks on this call have had this experience. Once you start writing and it just sort of spills forth, there's a way in which you feel compelled to keep writing. And I have no doubt that Jacob knows what I'm talking about, as he is prolific. I'll turn it over to him.
Sure. Well, I appreciate that introduction. To my mother, though, I'm still her son who's not the rabbi. So it's all contextual, which is actually an improvement, because she used to say he's a psychiatrist and then pause and say he's almost a real doctor. So I guess I offer the psychodynamic answer that we all write to fill the voids in our childhood and to prove ourselves over and over again. Though the specifics of my book, Who Says You're Dead, which is my ethics book, I really wanted to write a book that lay people could explore. On bioethics, clearly Lydia and I both think it's a fascinating field, but I don't think the average person is aware of the exciting things and important things we do. And the goal was to write, rather than for an academic audience, for an audience of people who can read these dilemmas in their car and fight with their spouses.
I just want to show, so this is Jacob's book and Lydia's book here. And both of these books talk a lot about issues that we started maybe to think a little bit more about during the pandemic, but they were written before the pandemic. So there are things that you learned and ways that your perception of the topic changed during this last year.
Were there ways, you asked, Leslie?
Yeah, were there ways where things changed from the way you were thinking about the book beforehand?
So as Leslie mentioned, I'm a general medicine doctor, practicing internist, and I moved to New York City, 6 months before the pandemic hit, not expecting that we would move to a city that everyone wanted to leave all of a sudden. But I also was, as so many of us were, redeployed, as the language that we've been using in the hospital, redeployed to the front lines of COVID care, working in capacities that, frankly, I had no training in, no business to be working in, mostly in the emergency room. But then also as a clinical ethicist, it was really ethics committees that were tasked with trying to come up with contingency plans for allocation of scarce resources, which a year ago, of course, we all thought was the ventilator, and that was the thing we were going to run out of. If you've watched the news today or yesterday, in India, they've run out of oxygen in many places. So we found that there were different resources that were scarce, that the pandemic affected people in different ways. But one thing that we can say unequivocally is that the idea of death and the need to prepare well for death certainly came to the fore in the last year. Now, whether or not people who did not die or were not affected by sickness themselves choose to do anything about that is the $1,000,000 question. But it certainly put death in our faces, put sickness like we haven't seen in our generation at all in our faces, and forced us to wrestle with it. So it's been quite a raw year as a medical doctor in New York City, for sure.
So before we go on to you, Jacob, I realize that, people joining us might not totally know what your book is about. So could you give us a quick introduction, which probably should have come first?
So The Lost Art of Dying riffs in a way off the bubonic plague from the mid-1300s. So when the bubonic plague struck Western Europe, historians estimate that perhaps as many as 2/3 of the population died. And this left the survivors with a real dilemma, namely that they weren't exactly sure if those who had died had been properly buried, if they had, in the Christian tradition, received last rites, if they'd had a proper funeral. Had the priest sort of done what he was supposed to do to make sure that the souls of the departed were safe, right? This is the late Middle Ages. People were kind of wrapped up in this world of needing assurance. And what developed during the aftermath of the bubonic plague, which has also been referred to as the Black Death, was a genre of literature referred to generally as the ars moriendi in Latin, Latin for the art of dying. So this art of dying body of literature, we think that the earliest iterations were deployed by the church probably, but subsequently there developed many iterations for different languages, cultures, religious groups that were not Christian, and even non-religious groups, such that by the 1800s, the historian Drew Faust, former president of Harvard University, she writes in her book on the Civil War that whether you were from the North or the South, whether you were religious or not, the preparation for death was just something that you did over the course of a lifetime. This was just part of living well. You had to live with a view to the end, because we're all going to die. And so there's no use pretending that we won't. The closest thing we get to it today is probably estate planning or your retirement accounts. But in the 1800s, and really for this 500-year period that this genre of literature was very popular, it was just kind of in the thinking that we had to live life well with a view to the end. And that meant investing in community. That meant thinking about what a virtuous life might be. What is honor? What is integrity? What is courage? And how do we cultivate those sorts of character traits? So anyway, I stumbled across this genre of literature about a dozen years ago when I was mulling over how poorly we die and how poorly many of my patients have died in the hospital. and sort of, regretting these deaths, which, and these dying processes, which in many ways were sort of self-inflicted. They were sort of chosen by patients. At the same time, it just felt wrong. And so I had been thinking, how could we do this better? And really, how could we empower individuals who are not physicians to start to ask questions and make preparations themselves? If in the late Middle Ages, the priest was kind of the intermediary again, we're talking about dominant Western culture. I recognize there are other religious groups and non-religious groups, but this 1300s in Western Europe, it was largely the priests who were the intermediaries between life and death. And if it's the physician today, although any nurse would say it's definitely the nurse and not the doctor, if it's the physician today, the clinical person at the deathbed, who's really that intermediary between life and death, and medical people are abdicating their responsibility to help patients prepare well, then we need to empower patients to do that work themselves. And so that's the book that I wrote. I wrote The Lost Art of Dying for my patients, sort of pulling off of this idea of the plague and asking how we might give some basic skills so that patients are equipped to face the hospital, but also to live well in order to die well. So that's sort of the thrust of my book.
Great, thank you. Again, I realize we should have done that before I asked you that question. So, Jacob, you touched a little bit about what your book is about, but maybe you could do that a little more thoroughly, and then, segue into the question of what's changed since you wrote it, because obviously we've had this major medical catastrophe.
Sure. So I can give one anecdote from my book that gives you a sense of the kind of dilemmas I raise. And I'll just offer the first one, where a pair of brothers come forward and they're being tested to see whether they're a kidney donor for their father. And it turns out there's bad news and there's worse news. The bad news is that they're not a match for their father, and the worst news is they're not his biological children. And then the ethical dilemma is, should the hospital tell the parents? Should the hospital tell the children? And then once you come up with your answer to that, there is at least one case I'm aware of where a couple came forward to give kidneys to one another, or one to give a kidney to the other, and they discovered not only were they a match, but they were biological half siblings. And then you can ask yourself the same set of questions at a higher stakes. So those are the kinds of questions I ask. That being said, everything has changed now. I think the two lessons from the pandemic are, one, there is an enormous disconnect between what we are doing as bioethicists in academic centers and what the world is aware of, what they're prepared for, what policymakers are engaged with. And I'd like to say we've made a lot of progress, but I think it's generous to say we've made a little bit of progress. And the second thing, I think it's impossible to ignore the racial advocacy that occurred over the summer and its implications for many of the bioethical issues we talk about. Particularly, we set up lots of triage regimes for ventilators, for scarce resources, that assume that everybody starts more or less at the same place societally in terms of their healthcare and empowerment. And the reality is we have a system where some people have been shortchanged all along, and we have triage systems that penalize them for lack of healthcare that they received over the years.
That's a big topic, of course. As you think about it, both of you, are there ways that you see that how can we do better in that department? And how did the pandemic bring those, the pandemic brought those things to light, but is there a way to segue into a solution?
Well, so maybe I'll just flesh out with an example what Jacob just alluded to. So in the early days of trying to come up with recommendations for how hospitals should handle projected ventilator shortages, there was a lot of concern that if we left it up to individual clinicians' own discretion, that they would, somehow base their decisions on biases. Perhaps implicit biases, but biases nonetheless, right? So there was a real drive to come up with an objective scoring system to determine who is sickest and thereby who should have the ventilator, as opposed to who has the highest chance of survival. So it's this kind of dance between, if you're too sick, if you're too sick and dying, we don't want to use a ventilator for you. But if you're not sick enough, we also don't want to use a ventilator if you really don't need it. So it was kind of trying to find that sweet spot. And one of the things that was thrown around a lot was a scoring system that looked at laboratory values that we could order in the hospital, that blood draws and vital signs that were easy to check in the hospital, and then calculating how impaired organs would help to give this score. And this was something that had been discussed years ago when we were trying to come up with protocols for handling ventilator allocation in the event of a terrible flu pandemic, right? So it was originally conceived of for influenza pandemic. But as it turns out, because of underlying medical conditions, genetics perhaps a part of it, but also social stress and racism in healthcare, where racial and ethnic minorities have often received inferior care. It turns out that these scoring systems often show racial and ethnic minorities, mainly Black and Hispanic patients, as being much sicker and perhaps too sick to merit the ventilators. Right. So then you get into this conundrum, because we want equity. And that's why we want the scoring system, because we don't want it to be the individual doctor saying, I like you, but I don't like you. Therefore, the one I like gets the ventilator. And yet the supposedly neutral scoring systems revealed to us that there are these big disparities in healthcare, which, we've sort of talked about for years, but they became very obvious, especially as COVID disproportionately affected Black and brown individuals. So it's tricky, right? And I think I think part of what the pandemic did is expose perhaps our hubris in trying to think that there's a way that we could definitively solve the problem, and it was humbling, and perhaps reveal that there's far more ambiguity. And stuff is a lot more confusing than we thought, which makes it really tricky to try to solve. I'll say that there was an idea put forth in Canada that when there was projection of another wave coming post holidays, of a random, you just basically put all of the patients in a hospital into essentially a random sorter that would just spit out numbers, and the patient whose number was spit out would get the ventilator, and the patient whose number was not spit out would not get one. And I was on a call with some bioethicists who were saying, this is great, because now, we don't need to worry about these scoring systems, which are sort of rigged with biases anyway, and we don't need to worry about individual doctors' implicit biases. We can just, put the numbers in, and it'll spit out, and it'll tell us who gets it. But the problem is you still have a doctor who has to go to the bedside then of the 27-year-old father of two and say, I'm so sorry, sir, I know you need a ventilator, you're dying, but your number wasn't chosen. And so it didn't exactly resolve the conflict that we face. I don't know, Jacob, I'll turn it over to you to fix everything I just said.
No, I agree with the most of it. I mean, the problem is who puts the algorithm into the computer. I think the real dilemma occurs. There are individuals who are often low income, often ethnic minorities, racial minorities, who live in communities that are food deserts, who get substandard healthcare, who end up with conditions like diabetes and hypertension through a systematic failing. And then we have a system that penalizes you when you allocate ventilators for having hypertension or diabetes, or a whole host of other ailments. And the pressing dilemma is, on the one hand, we view that as a threat to justice and equity in healthcare. On the other hand, even people who believe in affirmative action or holistic review for education or employment are very troubled with the idea of giving someone a ventilator with less chance of survival over somebody with more chance of survival, simply because of their ethnic background and experience. And so there's no acute solution to that. I think the solution is to step back and think, maybe we want to set the world up in peacetime, so when we have another pandemic, we don't have to face these crises.
Yeah, that's good.
It's a big issue, which will take a long time to sort out. So we're sort of not getting to the end of the pandemic, but things are starting to look a little brighter and more hopeful. What are some of the ethical questions that you're grappling with now as we're enter this phase of, some people are vaccinated, some are not. Will people be able to travel if they're not vaccinated? Will we have vaccine passports? Those are some of the things that I'm thinking of, but what are some of the things that are on your minds now?
Jacob, you want to go first?
Sure. So I will say we may be at the end of the pandemic, but as Oedipus says, count no man happy until he is dead. We will know we're at the end of the pandemic in 50 years or 100 years. Or which Xiao Enlai was asked about the French Revolution and its impact, and he said it was too early to tell. So with that in mind, I think the major concerns I have are one, issues related to mass vaccination and whether we're going to require them. And more importantly, if we don't require vaccination and don't reach herd immunity, will we eventually have breakout variants that undermine the entire system we've created? And to what degree coercion is acceptable to protect the rest of the public? But the second issue, I think, which doesn't get much traction right now, is all of the lockdowns and all the measures taken early on were complied with in the short run and then fell apart. My concern is if there is a second pandemic or any other public health threat, will the public respond in the same way? Or will they say that wolf was cried, even if it wasn't, and go about their merry business and leave us in a worse state? So I think we need to be thinking about the next disaster now rather than waiting for it to arrive.
Yeah, that's good. I was wondering, Jacob, if you were going to say anything about the mental health fallout as a psychiatrist from I mean, many people have been saying there have been pandemics within pandemics, whether it's the child abuse, the cases coming into the emergency room are much more severe than anticipated, or the hunger, 1 in 4 in New York City is estimated to be hungry, 1 in 6 nationwide, or opioid deaths are way up, opioid overdose deaths are way up. And of course, with the mental health, which all of this ties back to lockdown, economic shutdown are we as a people, Americans, are we capable of flourishing under those conditions, under the dictates of the government? And have we just shown that with 570,000 dead, we can't? I wonder if you want to say anything about the mental health fallout.
Yeah, I can say empirically, choosing my words carefully so I don't get fired, the volume of patients we have seen in the psychiatric emergency room has increased exponentially, not during COVID, but since COVID. I think partially because many people who desperately were in need of psychiatric care didn't come forward to get it. And now they've been out of the healthcare system for 6 months or a year. And then there are the dislocations of COVID itself. People who, 1 in 10 Americans is now grieving a family member. And this is not equitably distributed as well. And then finally, I think there are people whose lives were dislocated by COVID who didn't really realize the extent until COVID has started to wane. And now they have to re-enter the world on a very different footing. And that's very challenging for them. So yeah, I think the damage has been done, but we don't even have a remote sense of the degree of the damage yet.
Yeah. And Leslie, I think just to pick up on your initial comments and also what Jacob was saying, there is widespread concern that we're not out of this, so I like your language of now that, COVID is, we're past, I think you mean now that we are past the waves. And it seems like things, at least in New York City, are looking better. I mean, my parents live in Michigan. It's not looking so great there right now. And with what is it?
Optimistic. Sorry.
Say that again.
I'm being overly optimistic. My apologies.
Yeah, well, no. So then it raises all these interesting questions because vaccine mandates are certainly one. But if half the country or close to half the country does not want to be vaccinated or doesn't get the vaccine booster when that becomes available, which both Pfizer and Moderna are saying we will need boosters, certainly looking at the variants and the rate at which variants are spreading, there is concern that the vaccines produce what we say fewer neutralizing antibodies. So the antibodies that are supposed to help keep you from getting sick with COVID, there's a lot less if you are exposed to some variants. So basically the vaccines aren't quite as strong with some variants. So then what happens is if you don't have half the country or 40% or even 30% of the country vaccinated, it becomes, and even if you do, right, but then you just have a wider pool for becoming sick. And every time the virus spreads, it's mutating. It's constantly mutating. And not all of those mutations are concerning, but certainly some are. I haven't had a chance to read on the, there's supposedly a double mutation in India that is, I haven't read about the specifics of it yet, but it's concerning. And certainly we have our own New York City variant, which started in the, what we think traced to the neighborhood of my hospital in Washington Heights section of New York. So, so there is good reason to be concerned. And you're right, the ethical issues then are, can you force this? What kind of public health measures can we take? Can we require it as a condition of employment? And certainly there's a lot of suggestion that we will be requiring it as a condition of employment, just like, for example, in the hospital we do with the flu shot. Once the vaccine is no longer on this status of emergency use authorization. So the Food and Drug Administration says, yes, you can administer the vaccine, but it still is under this emergency use authorization, which means that it's haltingly administered. The vaccine is distributed, but with a lot of watching. And we've seen that, of course, with J&J vaccine being pulled temporarily. So once the vaccines become normalized, if you will, once they become approved sort of across the board, then we can expect to see mandates. And I think people should expect to hear that from their employers too.
Yeah, personally, I think a preferable approach would be a carrot rather than a stick, that we simply pay people to get vaccinated, because it's the idea of finding people or imprisoning people or throwing them out of work or not letting them go to school. It's easy to protest and fight against. It's harder to say, I'm upset that my neighbor got a $1,400 check. And there might be economic benefits to that as well. But my guess is a lot of people who in principle are opposed to getting vaccinated might feel very differently if they got paid a lot of money to do it.
Lydia, I also wanted to ask you about, so part of your book has a lot to do with dying surrounded by your family and friends and the network that you've basically created your whole life. And of course, during the COVID deaths, people were dying alone or maybe dying, with their phone and the family on the phone. How do you think that has affected the families? And also, I guess that's not something you could have ever predicted when you were writing this book, but how did that make you feel as you were treating folks?
Yeah, no, that's a great question, Leslie. I'll say that as I said at the beginning, when I was talking about the Ars Moriendi, this art of dying body of literature, of all the various iterations, there were two common themes among them. Well, there are many things, that helped these books belong to the genre, but I would say that the two, if we were to say, well, what's an art of dying today? What is it that we need most fundamentally? It's two things. One is an acknowledgement of human finitude, this idea that we are finite creatures and we can't escape that. And we need to sort of walk toward that, even if it's a little bit uncomfortable for us. We can't live without that sort of certainty in front of us. We can't live and then expect to die well if we don't, at the very least, acknowledge our finitude. But then the second thing that is really fundamental to the genre of literature is the role of community. And people often ask me, they'll say in Q&A when I'm talking about the book, well, look, I'm a loner. I'm an introvert. I have two good friends in the world, or one good friend. I don't have a village, right? And my response is always, you don't need a village, right? You need someone. And how are you cultivating that relationship or those relationships with a view to the end? I had somebody say to me once, look, I know who I want to be at my deathbed. I have them so like I can see them in my mind. I close my eyes, there they are, but I really can't stand them right now. So can't I just wait until the end to sort of reconcile with them? And of course, the question is, well, when is the end, right? And if COVID has shown us anything, it's that death can come for any of us at any time. So if you do the work of building those relationships, reconciling those relationships, nurturing them now, not only will they be richer now, and you will enjoy them, and they'll just be a depth to those relationships now, but that'll carry forward and build over the course of your life. In the late Middle Ages, it was very fashionable that when someone in the parish, the Western Europe divided up into parishes, when someone in the parish was dying, the whole parish, right, the whole village would parade past the deathbed, whether you knew these people or not. And that is not the kind of dying that I'm advocating for. An anonymous throng sometimes feels that way if you're dying in the hospital, perhaps, but that one or two close people. So Leslie, when you ask about COVID and the lonely deaths, there's so many things that have been upsetting to me about the pandemic. I alluded to a few. Certainly, what's gone on in New York City with children and schools. I have school-age kids. It's devastating. Certainly, the abuse, the intimate partner violence, as we say, domestic abuse. There's on so many levels. It's been upsetting, but I do think that one of the greatest tragedies coming out of this pandemic is the lonely dying and the lonely deaths. People who've lived a lifetime in community. My own aunt, actually age 90, lived independently, very vibrant social life, had her wits about her, her own apartment, hosted a lot of people, got COVID, 20 days in the hospital. She was allowed one phone call a day and no visitors. And she died alone. And it's sickening. And what's even more sickening is that people are eating in restaurants and they're getting on airplanes and going on vacation. And I actually just came back from Tennessee where I think I was one of the only people masked. And yet we still haven't opened up many of our hospitals and nursing homes for visitors. Even though the Centers for Medicare and Medicaid Services recommends it, many nursing homes are so afraid of letting COVID in the door again and all of the fallout we had a year ago that we are keeping older folks and those with disabilities who live in long-term care facilities essentially locked up. And to me, that's just sickening. I'll just say one last thing and then I'll shut up. There was a survey done by a nonprofit that advocates for folks living in long-term care facilities. And they did interviews last July and August of these individuals. Now, the respondents were those who were able to type their own responses. So this is already selecting for a group of people who are more articulate and tech savvy, but they're folks who live in nursing homes. And one woman said that she lived in the same facility with her elderly husband, and they had not been allowed to see each other for 100 days at the time that she completed the survey. And I just imagining this, right? What are we doing? What are we doing as a society while the world is moving on? And certainly, many people don't even care about lockdown anyway, right? They're just sort of living free. Why are we still treating our seniors and those with disabilities like this? It's just heartbreaking. So yeah, obviously by my extended answer, it cuts to my heart, and it's awful.
I didn't want to interrupt, but I'm sorry about your aunt's I'm sorry about this whole pandemic, but it's a sad personal note.
I will add to that. I do want to say, I disagree with one thing Lydia said, which is that I do want the entire city to stop when I die and all of New York to parade past my apartment. 8 million anonymous mourners, but I may be in the minority on that. I miss the days of paid mourners. But that being said, I think stepping back from what Lydia said, I think we need to look at the loneliest pandemic of the living, which really gives us a window into that. People may know the former Surgeon General, Vic Murthy, has written a lot about loneliness in the US. There's now a minister of loneliness in Great Britain. The data shows, particularly among the elderly and the most vulnerable, that large segments of people have no single person to share a secret or personal problem with. And that's a new phenomenon. The data from the American Community Survey says that in the 70s, loneliness was relatively rare. People had friends and family to rely on. And the way we live now, they just don't. And I think it's the lonely living that leads, at least in part, to the lonely dying.
Jacob, would you say that, in the field of psychiatry, as a psychiatrist, do you ever feel that you are that person that some of your patients go to, that you are their one social connection? I certainly feel that way as a primary care doctor, that some of my patients, especially older folks, would, in my previous practice in Connecticut, they would come to me for hugs. I knew that they were coming in and they probably had no human contact, and I would hold their hand and they'd always hug me at the end of the visit. And I knew that that was as much of the therapy as, their high blood pressure drugs.
No, absolutely. Less so now that I work in an emergency room, but when I worked in the clinic, absolutely on a regular basis. And on the one hand, you want to be generous and loving to people. On the other hand, as a social phenomenon, it's really a problem because the other structures these people need to thrive and have meaningful lives have really been taken out from under them. And I'm not some radical traditionalist, but when you take away the family and you take away the church and you take away the civic organizations, you end up with lots of people living alone in SROs and scattered at site housing who know no one. And that's awful.
And I'll just say, maybe to add on to that, with the pandemic, Leslie, another thing that we saw is a lot of people coming in with COVID, unable to speak for themselves, no next of kin, no documentation of advance directives or DNR orders, the sort of specification of their wishes at the end of life. And as you've probably all seen, the estimate of the number of bodies buried on Hart Island, which is essentially our they used to call them paupers' graves. It's our where we're burying the dead from COVID, whose bodies were not claimed. It's estimated to be 1 in 10 of New York City deaths, which is amazing, right? And sort of further to Jacob's point, if there really is this loneliness epidemic, which we believe there is, I think Japan also just appointed a minister of loneliness. Then that makes sense that 1 in 10 bodies would not be claimed from the pandemic.
Yeah, I mean, I would hope that there would be a drive post-COVID to get people to fill out healthcare proxies and living wills. I will be honest, I have seen much less of that than I expected. I had thought maybe that one of our political leaders would go on television and do this, but I still keep hoping.
Right, that's a good segue into a question that I have. So both of you in your books are putting forth a lot of issues, and especially you, Jacob, putting forth just question after question. That's what the book is, these ethical questions. What questions should we be asking ourselves now as we are not over the pandemic, but maybe over the first hump of the pandemic, about how to die well, but also the ethic questions that, that we should all be thinking about? And
well, I think we should be thinking about the next war, so to speak. I think we have a bad habit of fighting the last war. Everybody remembers the Polish soldiers going into battle on horseback against German tanks. And we do that over and over again. The 9/11 Commission talked about 9/11 being a failure of the imagination, being a failure of policymakers to think about what was next. And COVID in some ways too. There are countless ways in which we can anticipate things that may threaten us. I will only offer 2 of those. One, as we make medical records more interoperative, so that you can go online as a provider and find out somebody's medical record from a different area, which has many assets to it. There's also the risk that a hacker in Russia or China will hack into the agglomerated American record system and post segments of the American medical record online, which would be a social disaster. And the second, which gets no traction at all, is geothermal weather and geothermal storms, and basically the role that those could play in destroying hospital infrastructure. There are ways that hospitals can harden themselves, backup transformers and the like, to prevent a cataclysmic solar weather event. And to my knowledge, most hospitals have not.
Yeah, Jacob, I don't know if you saw, when was this? At some point in the last year, a number of hospitals, IT, I mean, there were threats, right? There was a threat against hospitals, particularly in New York City, but I know around the country, I think 7 or 8 sites around the country, where they were essentially taking the electronic medical record hostage if a major health system didn't pay out. The nurses couldn't have access, or they would, information would be disclosed. So that is a real threat. I know, IT departments are tuned into that, but whether something needs to be done more broadly from a policy perspective, I agree. There's not a lot of traction on that. I would say, Leslie, to answer your question, I'm interested in policy questions, but I'm not in that space beyond what happens in the hospital, right? So I do help with policy, ethics policy in the hospital. And this gets to a question from Linda Carpino in the Q&A too, but I'm really interested in the individual advocacy for dying well. And part of what I think that must include is an understanding of what actually happens in the hospital. So interesting to me is that some folks at Harvard actually did a study where they looked at who was most likely to die in the ICU with aggressive life support and who was least likely to enroll in hospice. And it turns out that it's people who describe themselves as being highly supported by their religious communities. So and in their study in the Boston area, this turned out to be mostly people from the Christian tradition, which is a tradition that has professes faith in an afterlife, right? And so why is it then that these very religious people who believe in the resurrection of the dead and heaven, right, and living forever, also tend to cling most fervently to life support and to technology? So what's going on there? And it turns out, so these folks at Harvard did a follow-up study because they were very interested in this question, and they hypothesized that a lot of people receive, especially these highly religious people, receive direction from their clergy. So they did interviews with religious leaders to find out what the religious leaders thought about care of the sick and dying, especially at the end of life in the hospital. And it turns out that religious leaders far overstate the benefits of particular interventions and far underappreciate the burdens. And in their sort of passion to encourage the faithful not to give up hope, they encourage this technology at the end of life. But we also have data that show that if people are informed about what CPR, for example, cardiac resuscitation, actually entails, if they watch videos of it, they are much less likely to choose it for themselves. Because it often doesn't work in real life, or if it does, it's temporizing. It only buys you a few hours, a few days, unless it's a young person with a relatively healthy heart. That technology often doesn't do much for you, but it does cause significant additional suffering and a lot of other problems that develop during that process. So my point is, I guess, to Linda's question is, what is a good death with these extreme measures? Well, there are some people. A good death is, I can have some objective statements about what I think a good death is, but those are still subjective because I work in the space in the hospital, and I have strong feelings about what is good and not good. Having said that, there are people who, by their very nature, not to play the psychiatrist on the call, but they are people who are fighters by nature. And it would be antithetical to their character to accept anything less than maximum technology, than maximum treatment. In my book, I actually write about the literary giant Susan Sontag and her dying, which by all accounts, including by her own son's accounting, and he's written a memoir about this, it was awful. Her dying was awful. She refused to acknowledge that there was absolutely nothing else. And she was, to the end, sort of handfuls of chemotherapy pills, stuffing them into her mouth while her body was decaying. It was awful. At the same time, it was very consistent with how she had lived her life and how she had described her values. So even, if it was traumatizing to the community, which David, her son, writes about, it was consistent with who she was and how she lived her life. And so by some measures, that is a good death. But overall, my goal is that people be more informed, because it's about empowering individuals to know how to navigate living well and dying well.
Now, a lot of my work is with resource allocation and statistics. And one thing I've taken away from the end of life debate is most people think they're going to be an outlier. So I always tell people, if you're diagnosed with ALS and the prognosis is maybe 2 to 5 years, and you type in ALS prognosis in the internet, historically, the first thing that came up was a picture of Stephen Hawking, who lived 40 years. People always think they're going to be the tail. So you tell people a third of Medicare dollars are spent in the last 6 months of life. That's a meaningless figure, because if I ask you on the call, how many of you were in the last 6 months of life, nobody's going to raise their hand. And balancing realistic hope with denial with realistic healthcare data and outcomes is really a large challenge, both on a macro and a micro level.
I also wanted to get to another question from a participant, Christy. She asks, would there ever be a time ethically when those who are vaccinated for COVID might receive a hospital bed and treatment before an unvaccinated person?
Sure, I can take a first pass at that and then hand it over to Jacob. This was something we talked about a lot last year, which was, should those spring breaker college kids who are going to Florida, and we all saw the pictures in Miami a year ago, of course, you know, history repeats itself. Should they be hospitalized? Should they get ventilators if by their own rash behavior, they become sick? But that question extends into so many different domains of medicine. If you smoke cigarettes, should we treat you for lung cancer? If you don't exercise, should we treat you for heart disease, which is developed by your own laziness, right? I mean, they're like, this is, I'm painting it in extremes, but you can see where we're going, which is that generally the position of medicine and medical doctors has been to do good, not do harm, right? And to not blame patients for their disease. Now, have we been perfect about that? I mean, HIV is a great example of how there was all kinds of finger pointing, name calling, and blaming for disease. It's a particularly vivid example, but it happens all the time, whether it's smoking and obesity or COVID. So my sense is that, you know, I'm just looking, Christy, really quickly at your question, when those vaccinated for COVID, yeah, I don't know that we would, well, I'm sure there's always mumbling under the surface, but we would never craft policy where we say, okay, you're an anti-vaxxer, well, sorry, we're not going to treat you, or you don't get the hospital bed, or you don't get the ventilator because of your anti-vaccine status. We wouldn't do that. But Jacob, I don't know if you want to add a spin to that.
Yeah, I think the complexities of why people don't get vaccinated and the histories of why they may not to and distrust are so complex, we wouldn't be able to operationalize it. But I also refer people back to what I think is one of the seminal events in bioethics, which is the God Committee from Swedish Hospital in Seattle in the 1960s, where there were a limited number of dialysis machines, and the committee in charge of allocated them based on perceived social worth. And you can read the transcripts of these hearings in Life magazine from the 60s, and they're heartrending. Discussing whether someone who is religious and is going to die young should be given an opportunity for a dialysis machine because they're a good person, or denied it because they're prepared for an early death. And therefore, with medicine, as physicians, we don't want to get into the business of figuring out how people got diseases, why they got diseases. We want to treat the patient in front of us.
Yeah, that's right.
Another question I had, it's a little bit like a question I asked earlier about how we should be preparing, but how should we personally be preparing, you know, for our good death, for what, and why is it important to ask ourselves these ethical questions now in so-called peacetime or in health times, as opposed to, you know, waiting till the end and you know, you get a diagnosis and then you think about all these questions and what the ramifications may or may not be.
Leslie, I want to get to that question, but Jacob, I'm going to pivot back to this question of social worth really quickly. Was it the National Academies of Medicine's proposal for vaccine distribution included a criterion that was not quite like social worth, but it surprised me, which is that there was sort of widespread agreement that frontline healthcare workers and folks in nursing homes and extended care facilities should get the vaccine first. But one of the other ways that they proposed thinking about who should get vaccine was, I can't remember exactly how they worded it, but it was something like negative impact if they died or something like that. So what this meant was, was essentially reinforcing young, productive people in the workplace, particularly those who were teachers and doctors, as getting vaccine first. And I remember thinking when I read those recommendations by the National Academies of Medicine, this feels an awful lot like social worth without actually putting it in those words. I don't know, did you ever see those recommendations? Do you know what I'm talking about?
I know what you're talking. I don't remember reading them, but I know what you're talking about. And I think to emphasize, using social worth is not just unjust, but it also severely damages the healthcare system because it undermines other people's trust in it. So if people perceive that a famous celebrity, for example, gets a liver transplant ahead of other people, they're less likely to donate livers. People who perceive the system is not allocating resources fairly may be less likely to quarantine, less likely to follow healthcare measures during a pandemic.
Yeah, I'll just say that one of the organizations that I teach for is the Fellowship at Auschwitz for the Study of Professional Ethics, FASB, and we take over to Berlin and to Auschwitz. We take a group of medical students and seminary students every year to study ethics, essentially on site. And one of the things that physicians were particularly culpable for was determining during the Holocaust whose life is worth living. And really the train cars full of Jewish individuals, as well as sexual minorities and other groups, gypsies, the Roma people as they're called, would step onto these platforms, and doctors would life worth living, life not worth living. And I think we want to be really careful through the lens of history of not buying into categorizing people based on perceptions of social worth, because that becomes really problematic, quite toxic. Yeah, but back to your question, Leslie, if I may. So where do we go here? I don't know, Jacob, do you want to go first? I sort of have a few thoughts in mind, but
mine are so simple that they don't need a bioethicist to answer. The way to prepare for a good death is to lead a good life, and to engage meaningfully in community. And it sounds cliche, but it's really not, to realize that you could be one of those people whose life is only going to last 6 months. And you want to have all your ducks in a row accordingly, not just legally and financially, but also socially and ethically.
That's great. And just looking at Linda Carpino's question about, well, what if people change their minds when they are faced with catastrophic diagnosis? This is something on people's minds a lot when they think about completing DNR orders. I might say, I never want to die in the ICU. It would be dreadful. And I might complete a DNR order. And then I find myself in a very completely different health condition. Maybe it's a diagnosis of ALS, to use Jacob's earlier example. And I think, well, if I'm ventilator dependent, but I can use my eyes to type and I can interact with my family, that is a life worth living for me. And now I don't want to be, DNR, or I want to retract my anti-ventilator orders, because the ventilator is going to enable me to continue to live in community. And Linda, to your question, I think that's part of the reason why we need to be constantly, and by constantly, I mean sort of annually is an appropriate time, re-examining kind of where we are, what's the state of our health. I'm a primary care doctor. Part of what I have to do every year at the annual Medicare exam, called the annual wellness visit, is I'm required by Medicare to ask my patients annually about their end of life wishes. And if you're on Medicare and your doctor doesn't do this at your annual, you talk to your doctor. I'm empowering you to talk to your doctor, because it really is a requirement of Medicare. And it's too easy for patients to check the box, I don't want to talk about it, and for doctors to check the box saying the patient didn't want to talk about it, when in fact we should be going over this. And you're right. I mean, there's great data to show that people who imagine, for example, that they would never want to live quadriplegic in a wheelchair, once they find themselves with that high cervical cord injury, without movement of any of their limbs, living in a wheelchair, life is not as bad as they feared. And there's great data to show that. So we do change and adapt in circumstances. Human beings are incredibly resilient. So that's why it's got to be a conversation over time about how to engage with healthcare, and not just a one-off. But I'll just say quickly, the three ways that I like to, the three domains, if you will, that I like to encourage people to think about while they are healthy, while it's peacetime, to borrow from Jacob, are the medical domain, meaning talk to your doctor, watch the videos about CPR, understand what life support means, understand what hospice and palliative care have to offer, and sort of do your homework, and really press your clinicians for answers about kind of where you're at with your own health. So the medical domain. The second domain is the community domain, assessing the state of your relationships. With whom do you need to reconcile? Where are you in your community? What sort of work needs to be done to strengthen the community, even if it's just that one other person? And then the third domain really is the existential. I've sat with patients who are really at the very end of their lives, who are suddenly asking these questions about fear of death. What do I believe? What is this life for? What about the afterlife? Do I believe in that? And, when you're actively dying, it's kind of, it's almost too late to sort of come to a clear understanding. So in the context of your communities, wrestle with these questions and sort of address them head on. And, you don't need to reinvent the wheel. There's a lot of wisdom, a lot of philosophy, a lot of theology, around the world written on this stuff for thousands of years. So there's no need to sort of make it up from scratch, but do a little homework, do some reading and talking with people far wiser than yourself, and try to come to a place of peace individually. But I think starting in those three spheres, the medical, the community, and the existential, is a great way to kind of get started.
And one could even say that everything that's ever been written is to grapple with why are we here and what do we believe.
Right, that's what philosophy is for, right?
We're almost out of time, but I just wanted to ask you both quickly if there's anything we should be looking out for from you in the future, follow-up projects, different books. So tell us what you're up to for the future.
Well, I'm always scribbling away. And my new short story collection, Winter Honeymoon, came out in the middle of the pandemic, so I can still consider it a new book. And if people want something that has very little to do with death and dying, Winter Honeymoon might be a good relief for them.
Thank you.
Jacob is more productive than I. I actually have a couple of book projects I'm working on, but they're so in their infancy, it's not worth talking about. But yeah, we're still scribbling away is probably the best way to characterize it. So.
Right. Well, I understand that, having at least 4 book projects going myself and no books under my belt. So I want to thank you both so much for being here, and thank you for all your work during this horrible year. It's been horrible for everyone, but I'm sure you all have seen a lot, and we appreciate all the things you're doing on the front lines. So
I hope we see you again, but not during the next pandemic.
Agreed. That's
right. That's right. Thank you so much.
Thank you. And thank you to everyone who attended. We really appreciate you being here. I hope that you have a great rest of your day. And we have a couple more sessions tonight. Also the Melopea, which is at 7 o'clock, and a whole day of events tomorrow. So please continue to log in. Have a great day, everyone. Take care.